everyone's time. I think we'll get started now. So thank you so much for joining us for session 2 of the Women's Health Matters webinar series. We're really excited about the topic we're going to be talking about today, which is endometriosis and pelvic pain. Before we get started with the formal session itself, I'd like to do an acknowledgement of country. DPV Health acknowledge. I'm so sorry. Just give me a second. The computer is playing up a bit. Okay. DPV Health acknowledges the traditional custodians of the lands and waters on which our services and sites are located. We pay respects to elders, past and present, and extend our deepest regards to all Aboriginal and Torres Strait Islander people, including any who may be with us today. So before we dive into the session and the presentation itself, just a few housekeeping rules that I'd like to take you through. This webinar will be recorded and the recordings will be shared with participants as well as on the DPV Health website and via our social media for anyone who may be interested in going over it later. Can I request everyone to please keep your microphones off or muted for the entire duration of the webinar, just so there's no cross noise, there's no disturbances during the session. There is a chat function on Teams, and participants are free to submit their questions, queries, or even opinions anytime during the presentation. We will address questions either during the session or immediately after, based on how we were going on time. Also, this goes without saying, but everyone is requested to please demonstrate mutual respect and avoid any negative comments or criticism during the session. All right, with that, I would like to hand over to our extremely capable and talented women's health nurses team for a brief introduction about the service.
Hi, everyone. Firstly, I'd just like to introduce myself. My name is Shireen, and I'm one of the nurses at the Sexual Health Clinic here at DPV Health. It's a pleasure to welcome you all to our Women's Health Matters webinar series. Whether you're a health professional, a community member, or simply someone eager to learn, we're glad you're here with us. These sessions are about empowering informed choices, breaking down stigma, and making sure everyone has access to knowledge and support they deserve. So let's keep the conversation open and make this a safe space for learning and sharing. First, a little bit about DPV Health. DPV Health are primary care providers operating in the northwest of Melbourne, offering a range of services including allied health, dental, counselling and medical services. One of the services that are operated through our medical clinics is our sexual and reproductive health hubs. We offer a range of services to women. Some are led by nurses and others are led by the GPs. Some of the nurse-led clinics include the sexual health assessments, vaccination, cervical screening, implant insertion and removal. In addition to the nurse-led services, the GPs provide services including STI testing and treatments, pregnancy and fertility support and guidance, and contraception options. These are things that we're going to be speaking about today, which can be booked online through our website. The DPV Sexual and Reproductive Health Hubs operate from 2 of our medical clinics, which are at Broadmeadows and Mill Park. Both clinics are close to the train stations, so they are easily accessible through public transports. We have plenty of parking on site also. I'd just like to introduce our sexual health team now, which include our amazing GPs, Dr. Jellum at Mill Park, Dr. Christina Port at Broadmeadows. We also have a team of 5 GP registrars who work from our Broadmeadows location and have special interest in women's health. We also have a nursing team of 8 nurses who have all completed their comprehensive sexual and reproductive health training. Across the team, the GPs and nurses speak 9 different languages. We also have access to the interpreter service where patients that need as needed for patients to ensure that everyone has the same access to services. Appointments with any of our GPs can be booked over the phone or through our website. Another really important part of our team is our wonderful gynecologist, Dr. Vishali, who is our guest speaker for today. So I'll hand over to Dr. Vishali now. He'll take part in her presentation. Thank you.
Thank you, Sherry. Before we start, at any point, if you can't see me or hear me, please let me know. So we're going to talk about chronic pelvic pain and endometriosis today. And for centuries, women have been expected to suffer in silence. They were told, they are still getting told and taught that pain was normal and something all women endure, and it was their duty to simply bear it without complaint. But times are changing, thankfully. Now we understand that pain affecting women's quality of life is not normal. Women deserve to speak up, to be heard, and to seek help. Support and effective treatments are available, and every woman has a right to live without unnecessary suffering. All of us need to remember that. So chronic pelvic pain is a very wide topic, and that we will talk about it after some slides, but the major cause of chronic pelvic pain is endometriosis. So let's get started with knowing more about endometriosis. So endometriosis is an inflammatory condition in which the lesions of endometrial-like tissue is outside the uterus. What does it mean is that endometrium is the inner lining of the uterus, which is there for helping pregnancy grow. So the fertilized egg comes inside the uterus, gets embedded in the inner lining of the uterus, which is called as endometrium, and the endometrium then helps that embryo to grow into full-born human being. So this endometrium, when a woman doesn't get pregnant, gets shed every month as vaginal bleeding, what we call as menses. So this endometrium is supposed to come out from the uterus, through the cervix, through the vagina outside. But for unknown reason, this inner lining sometimes is found inside the abdomen. And we don't know exactly why this happens, but we have got some hypotheses or theories. So one of the major theory which we believe, hopefully it is true, that this inner lining of the uterus, which is called as endometrium, goes from the uterus through the tube and then falls inside the abdomen on the various organ and then starts reacting to the hormones which are secreted by ovaries. So this tissue undergoes the exactly same changes what the inner lining of the uterus undergoes. That means it grows and then it bleeds during the period. And that is the reason all the symptoms and signs and complications happen. So it's not a small thing. A lot of women suffer from this. It's a common condition, and we are getting more and more aware of this. Almost 700,000 women, Australian women and girls, are suffering from it. So as I said, that it can be because of the interaction, because of genetic predisposition, hormonal influences, and retrograde menstruation. That's what I talked about, that the menstrual bleeding, instead of coming out, goes from the tube inside the abdomen, and then that endometrium gets deposited in various organs of the abdomen and then start behaving this exactly the same way what it would do inside the uterus. And sometimes the immune dysfunction also plays a role. So finally, there is one thing which is not mentioned in this slide, is that some of the women have got more sensitivity toward the changes which is happening in those endometriosis tissues inside the abdomen. Because often we see the women which have a lot of endometriosis inside their tummy have no symptoms, and vice versa. So the amount of endometriotic tissue inside the abdomen does not reflect or correlate with the pain or the symptoms which a woman has. It's a long-term condition, just like diabetes, hypertension, for which we don't know the reason. And it does have a lot of impact on physical, sexual, psychological, and social well-being of a woman. Next slide, please. So it's very tricky to diagnose endometriosis because there are other reasons for the chronic pelvic pain. So the delay can be up to 7 years, which is really not good from the onset of the symptoms. So reasons of these delays can be because of the mites, menstruation-related mites, that this is just normal, put up with that, or cultural misinterpretations that you're not supposed to talk about the pain while you are having menses, and always assuming that dysmenorrhea, that means painful periods, are normal and it's a normal part of life. So having some discomfort, some pain is normal, but the pain which is affecting quality of life is not normal. That's where the variation is. The moment it starts affecting your quality of life, whatever it is, physical, psychological, social well-being, you are supposed to seek help. Also, the delay can be because of the pathways, difficulty in accessing pathways, difficulty in talking about right GP. Some women are not comfortable talking to a male GP, and then the GP is understanding how severe the pain is, and then getting referrals to the gynecologist or appropriate healthcare professional to reach to the diagnosis and form a management plan, or combination of any or all of these factors. Next. Oh, so looking at that beautiful picture. Oh, can we go to previous slide, please? So yeah, I have to talk about that beautiful photo which Bonnie has put in. Is that right, Pooja? So that's what the uterus is, and next to it are tubes, and next to them is ovaries. So the retrograde menstruation, that means endometrial tissue during the menses goes through the tube and then falls on the ovaries. You can see the endometriotic patches where they are. They are on ovaries, on the uterus, and sometimes in rest of the tissues of the abdomen as well. Next slide, thank you. So endometriosis can present with chronic pelvic pain, pain during the period or in between two periods, also pain while having sex, during or after. Also the women who are not falling pregnant after designated duration, like age matters in that. Pain while having poo, that is called as dysphagia. Fatigue or tiredness, because some women don't understand that they have pain, but they feel tired or fatigue after having menstruation, or even mood disorders. They're feeling so tired that they start getting sad about it or depressed, or anxiety or any other mood disorder can be also linked with endometriosis. So these are the various places where we can or we do find endometriosis. And it's amazing to see how many places it can grow. So we are looking from the side of the woman's body, and as you can see, there is a uterus there in the center. In front of it, there is a bladder, and back side, or toward the back, there is a spine, and then before that, there is a colon or a bowels. So the red spot indicate the endometriosis. So as you can see, sorry about my voice, all these places where the endometriotic patches can be found are on the vulva, on the perineum. Perineum is the place in between the vulva and the back passage or anus, over the bladder, over the uterus, in between the uterus and the bowel, or even on the bowel directly, on the tubes, on the ovaries, which is the most common place, and rest of the bowels, or even on the umbilical opening. You know, we have seen that, and on the different ligaments of the body, which can be very annoying. And these sites then are very difficult to diagnose, because these things like bowels or abdomen, they don't come to gynecologists. And then there is a delay which happens because other professionals are not very well aware of this condition, or they were not aware and slowly getting more aware of this condition's existence. Next slide, please. Thank you. So now this is the extent of the endometriosis, which like it's amazing to see where we can see it. You know, we have seen the endometrial patches even as far as the pancreas or biliary tract, that means on the liver, in between um, the abdominal cavity and lung cavity, like thorax cavity, which is called as diaphragm, or even the muscles of the upper arm and lungs and nose and brain. We have seen that. So endometriotic tissue has got these immature cells which can go in the blood and then can get deposited to different places. Like we have seen the endometriotic patches in kidneys or even in I can't see that. Even on the gluteal region, the muscles, different muscles like the arm muscle, the deltoid, same way we could see it on the big muscles of the legs or the pelvis or bumps. Next slide, thank you. So when a woman has such kind of pain, chronic pain, then we need to investigate them. So the investigations are blood test, some swabs, and ultrasound scan. So blood tests are usually to find out whether they have any iron deficiency, whether they have any thyroid issues, or even some clotting factor problem. And then, of course, we need to rule out any infection inside the uterus or in pelvic region, which can be sexually transmitted disease. So it's very important to screen the woman for STD and HPV infection, which can be found out from a pap smear or cervical screening test. And then, of course, the ultrasound scan is very important. The women who are sexually active can undergo a transvaginal scan. That means the internal scan, which is the most optimum way to find out endometriosis by non-invasive method. But those girls who have not become sexually active, they need to have only transabdominal. That means keeping the probe on the tummy and trying to look at the uterus and other pelvic organs. The gold standard is undergoing a keyhole surgery, the laparoscopy, in which we put a camera inside the woman's tummy after putting her to the sleep by general anesthesia and looking at the pelvis, that means the lower part of the abdomen, and then looking at the uterus, tubes, ovaries, and around that area. If there is a patches which we feel is the endometriosis, we usually take biopsy and send it to the pathology to confirm that these are endometric patches. So the young girls less than 18, they need to be referred to a pediatrician, and then usually once the pediatrician go through the initial management, they get referred to the adolescent gynecologist, and then they start getting properly managed. Next slide, please. So basically, understanding endometriosis is the most important way to manage it, because this is something which is ongoing. The pain is going to be there until that endometriotic tissue is going to be active. So right from the age when a woman undergoes puberty, that means when she starts having periods until she stops having periods. So roughly from any time in between 8 to 12, the girls are getting their menses nowadays, and in between 46 to 52, Caucasian or Australian women hit the menopause. During all this time, the endometriotic tissue is going to work all the time, every month, and then they are going to cause pain. So understanding what exactly is happening takes away the anxiety and stress, and that is important part of managing endometriosis. And that's why we are gathered here and talking about it. So that is the first thing. And then what happens is that why let's talk about why do we get pain during the period. Okay, why do we get pain when there is some infection or inflammation around the uterus? Because ovaries and the uterus, why are they kept so deep inside our tummy, which are very protected? The pelvic girdle is, they are strong bones, and the ovaries and tubes and uterus are right inside, because that's the way, nature's way to protect the human race, because these are the structure which are needed for species to grow. So any problem with that, the signal gets amplified and sent to the brain, so that brain says, wow, there is something going on there, I have to protect myself, I have to protect not only myself, the whole human species. And then the brain amplifies that and then act on it. Okay, and problem with that is that once that pain pathway is formed, even if there is no problem with the organ left, that pathway remains. I can give you an example that if there is a building construction is happening and people are using the road for that construction, okay, that road will still exist even after the building is constructed and if it is not used. Okay, so that's what happens, that even if the problem is resolved, even if the organ doesn't have that problem, that pathway, pain from the brain to the organ and the vice versa, it remains. And to remove that pathway, you need to take active efforts by your brain to abolish that pathway. And it's not an overnight thing which can happen. It needs persistent efforts. And to learn that, we have to go and undergo the cognitive behavioral therapy. And it itself is a big topic, and it's not exactly my territory. The psychologists and psychiatrists come in play. So believe me, this pain is not in your brain. It's not. It's a real thing. Okay. And you need to acknowledge it and form a plan, understand it more, and then negate it. Okay. So that happens over years. It doesn't happen in, as I said, overnight. Okay, it takes a lot of input from a lot of people, and help is available now. So to start with, understanding what is it, and that's what we're doing now. And there are a lot of online resources which have come up in last couple of years, and I have put a lot of resources and the links on in this website. Please feel free to click on any one of them and learn more about this condition. So anybody who has chronic pelvic pain or endometriosis, they should go to their GPs, and GP can then form a care plan, and that will help them to get some Medicare rebates when they try to go to the psychologist or physiotherapist or exercise physiologist and form a team to get better. So even the early life stresses such as adverse childhood experiences are being associated with developing this chronic pelvic pain. It is, as I was saying, that in my first slide, that we have seen, like when I do cesarean or even while doing hysterectomy, that means uterus removal, we see that the woman has a lot of endometriosis, but she never has complained to us. Whereas some women having a small spots, deposits of endometriosis can have severe pain. And that's where the childhood trauma or other like previous past experiences, bad experiences can get related to such kind of pain. So I also, this is a great topic, and I can go on on it for next 3-4 hours or even longer. But I also wanted to touch base about the complementary alternative medications. Women who don't find an answer in our allopathic medication or support, then they try to go to complementary therapies for endometriosis. And I'm not saying they're bad. There is, women can seek that help. Unfortunately, we don't have evidence, a lot of evidence which tells that it definitely helps. But you can go on Gene Health's website and they can talk more about complementary therapies for endometriosis. So most of these therapies are low risk, but anybody who's undergoing these therapies like Chinese medication or supportive medication, they need to talk with the pharmacist and let them know that, okay, I'm taking all these medication which are prescribed by my GP or my gynecologist, and along with that, I want to try taking this alternative medication like herbal medication or Chinese medication. Are they okay? Are they will I be safe taking these two together? And you should always think about the cost. Like if you're spending so much money, this money can be used to see a physiotherapist or exercise physiologist or a psychologist, which will take you through proper channels and make you feel better at the after some time. I'm not, as I said, that it doesn't happen overnight. So referral to the pain clinic is something which can help you better, rather than, I'm not, as I was saying, I'm not against complementary therapy, but you should judge where do you want to spend your money and time. Okay, so there are a number of treatments which are previously been considered complementary, and now a mass supporting evidence that they are used in mainstream medical practice, like mindfulness or restorative yoga. Unfortunately, Medicare doesn't have rebate, but yes, we have some evidence that this definitely helps. Okay, along with vigorous exercise and following good diet. Next slide, thank you. So I'll have to wear the glasses. So why there is more suffering in endometriosis or chronic pelvic pain is that the patient goes to the doctor, or if they don't go to the doctor, then then also there is a recurrent pain or management failure is there, and then there is an inadequate and doctor and patient relationship or communication, and then lack of understanding of the condition, lack on both sides, and lack of proper management, and then that goes to having a mistrust in the medical management, and then reduction in interaction with the doctor and with the society as well, and that causes social isolation and more psychological problems, and then it progresses to further stage. It's not doesn't remain just a physical suffering, it causes psychological suffering and then social suffering as well. So it affects the whole part of woman's life, the physical, psychological, social interaction, and then the family starts suffering. So we need to stop this. Next slide, please. So that's what about the endometriosis. It's only a touch and base, but we already passed half an hour. So let's talk a little bit about chronic pelvic pain. And at the end, I'll be talking about how we can manage the endometriosis as well. So chronic pelvic pain presents as a primary care as frequently as migraine or even low back pain, which is so common in community, and significantly impact women's ability to function. It can. So what is the definition of chronic pelvic pain? It's the intermittent or constant pain in lower abdomen or pelvis of a woman, of course, and which is lasting at least for 6 months in duration. And it is not exclusively happening during menstruation or during intercourse, or not even associated with pregnancy. So it's the symptoms, it's not a diagnosis. Okay, next slide, thank you. So as I had said before, there are multiple causes of chronic pelvic pain. The major cause is endometriosis, and the chronic pain, the other causes are due to different organ involvement. It can involve the GI tract, or it can be involving the musculoskeletal system of lower abdomen, or even nervous system, and even urological urogyny organs affection can also cause chronic pain. So there are different reasons. I'm not going into detail because they are just words, but anybody who's having those conditions should address those conditions properly and get treated, because their pain is real. So how do we manage the chronic pelvic pain? So it's the whoever is having chronic pelvic pain, their pain is usually worse during the period and what we call as dysmenorrhea. That means a pain associated with periods. So just keeping on watch or watchful waiting doesn't help. So as I had said, any pain which is affecting quality of life, you can wait for a month or two, but should not wait any longer than that. You should seek help. Okay, and the treatment should be individualized to the patient and what is getting more affected, whether their physical or psychological or social well-being is getting affected. That should be diagnosed properly, and then treatment plan should be formed. So suspected etiology of the pain and presence of risk factor for the development of chronic pain should be found out first, and then the management plan should be formed according to her priorities. So it's usually a multidisciplinary team approach, and the combination of non-medication and involving a lot of other faculties of the medical team, like psychologists, pain management specialist, and the neuroscience education, and the alternative medications shows like yoga or physiotherapist, exercise physiologists, even to some extent the occupational therapist. They get they have a lot to play with, and they have our strongest evidence in improving pain. So continuing exercises is very important. Like you can start with gentle exercises like restorative yoga, swimming, walking, and then adding up slowly to more vigorous exercises like stepping, jogging, swimming, horse riding to some extent, as long as you're not injuring. And the other activities to handle stress and sleep, refer to the psychologist. We mentioned that, and getting a mental health care plan from your GPs. Eating very healthy always helps, because ovaries undergo a lot of changes every day and they need really good nutrition. So eating a lot of veggies, fruits, salad, drinking a lot of water, drinking milk, eating yogurt always helps. And family input is very important. The partners, woman's partner understanding of this condition, or whosoever in its family, elders should also know what through the woman is undergoing. So they are there, basically the women's support team, and they should get involved as well. So following the website, which can assist the families and partners in caring the woman for the women with chronic pelvic pain, that Queensland Health and Chronic Pain Australia have got really good resources. So next slide. There are other resources which are available. They are free. Please feel free to go on those and get educated and start managing your pain. So Pelvic Pain Foundation, Ranzicog magazine, Gene Health A to Z periods. These are really good sources. Even Tem the Best is really good, and they are available in video form as well. So you should go on them. I would strongly recommend you to do that. Next. So all these information I gathered from Ranzicog website, and the resources are available on Ranzicog. Ranzicog is the Australia New Zealand Obstetrician and Gynecologist College website, and that information is available. There are a lot of resources there sitting there free for you guys to access them. I'm happy to take any question. I'm sorry it went on for 40 minutes almost, and it was quite it was packed up with a lot of information. But at any point, if you want to ask me any question, want some clarification, I'm happy to answer your questions.
I have a question.
Mm-hmm.
Hi, I'm Dr. Vishali. I was wondering if you have any strategies for women who are looking to go to speak to their GP about their pelvic pain, how to approach a conversation, you know, how to make sure that they are advocating for themselves and are being heard.
Yeah, very good question. I missed your name.
Liz.
Liz, okay, yeah. So, very good question. You know, first of all, first step toward understanding is that that pain which is affecting my quality of life. Like I would talk about myself, if I'm in that position, that I will first find out that if the pain is in the menses, how bad it is, what is getting affected. If it is my day-to-day life, or my work, or my sleep, or my family life, or my social well-being is getting affected, and I'll start writing down that. And I'll keep a diary, menstrual diary, pain diary, to see that with what are the days which are making me suffer more, and how bad is my suffering. You can even write on the scale 1 to 10. So there are a lot of questionnaires available on the Ranzikov guidelines. There is a RACE, RACE. It's a short form for a big long form. So the Ranzikov website has got that questionnaire, which takes you through almost 10 to 12 pages and asks you about how much you're suffering, what part of your life is getting suffered. Fill that questionnaire, and you can take that with you when you're going to GPs. But keeping a menstrual diary, a pain diary, a good start, and then making a big long appointment with your GP, giving them heads up that I want to talk to you, like making a small appointment and then telling them that next visit I want to come to you and I want to talk about my pain, which is affecting me very badly, and I want to form a plan with you, is a good start. So small appointment, then long appointment, and in between those appointments, you can ask your GP if they want you to fill in some questionnaires for you. Okay, because there are online resources which you can fill that up. But if you don't want to have that small appointment, then taking along with you your menstrual diary and pain diary is a good start. Okay, so for yourself, you can do that work, and you can always talk to your partner and your family to ask them that, how do I behave when I'm in pain? Because, having a third person perspective is also important, and what can be changed. And in that pain diary, you should always write down that what have you tried taking, what have you tried in terms of medication and non-medication, what helps, what makes it worst, and making yourself know that it is okay to talk about that pain, even pain while having sex. It's very hard to come up with that, So in pain history, you should talk about the pain while having sex, pain while urinating, pain while passing poo, all these things. That is the good start, I would say, and the severity of pain. Did I answer your question?
Yes, thank you. Thank you very much. That's some really good advice.
Yeah.
Hi, this is Rabia. I have
Hi,
a
Rabia.
question. Yeah, hi. So this is about my daughter. So whenever she has her periods, so before that she has a slight pain, and she takes a medication, and it stays just for a day. And so as I have heard that it's a very general thing, some women, they do have pain, before they're getting their periods, and some they don't have any pains or anything. So how do you describe the pain?
Yeah.
So
yeah.
Yeah.
So chronic pelvic pain is the pain which happens in the lower part of your tummy or inside. Okay. And as I had said, the discomfort is okay. The discomfort which is not affecting your day-to-day life. That's the bench. Yeah. So if the pain is too bad, like you can't concentrate in what you're doing, you're not able to enjoy what you're doing, you are trying to put off things to do, like I have a work today, or if I have a nice dinner party tonight and I am not wanting to go there, that's a severe pain. That is the pain which you need to deal with. Okay. So if you can get on with your life, taking a couple of Panadols, and if you can get on with your life and tomorrow you're going to forget about that pain, that means it's not that bad. Simple definition is making you not able to enjoy your life. That needs to be treated.
Beautiful. Thank you so much.
You're welcome.
Dr. Vaishali, there's a question in the chat. Marija is asking, just wondering if you have a list of specialist pediatricians and adolescent gynecologists that you can recommend.
Sure. So I don't have a list, but AMC, the Australian Medical Council, and even AMA, Australian Medical Association, their website I'm sure they have it, because I think I am on their website as well, and they have a dictionary in which they will provide you all these details. Unfortunately, in Melbourne, the things have changed. There are a lot of people available. We can go through that resource, and then we can talk about it, Pooja, and I can pass it on some names later on, and then you can circulate that information. It's
Sounds
a good
good.
question. Yeah.
All right. Does anyone else have any questions?
I have a question as well. Hi, my name's Rebecca. Sorry if I missed this before, but I was wondering, I know you were speaking about the link between sort of childhood trauma and endometriosis. Would you be able to touch on that a little bit more and how that is linked?
So the thing is, the childhood trauma or molestation or sexual abuse, it's not a cause, but there is association link. Okay, so we have not, like, there is a lot of, first of all, the problem is that such women don't participate in the surveys or the studies. So it becomes hard for all the ONGs all over the world to get exact evidence. Okay, so whatever the evidence is there is an association between the childhood trauma, physical, psychological, sexual childhood trauma, or even women who have undergone, like adult women who have undergone all this trauma, they have got association with pelvic pain. Okay, so as I said, that it's not a causative, but associative risk. We know that some things are associated with each other. For example, I don't know, this example is a medical example. This analogy may not be perfect. Like lichen sclerosis is associated with vulval cancer. It is associated with it. It doesn't cause. Okay, we don't know what is the reason, but we have seen that this happens. Okay, so it's like the person who has chronic pelvic pain, and we have investigated them, like not necessarily that we have to do laparoscopy, we can get a scan done and we find that there is nothing in there, but the woman is still saying that she has chronic pelvic pain. Then ideally they should be asked in first visit, that taboo should be, at least that barrier, we should, at least the medical professional should at least cross over that and ask that, the woman who have undergone such trauma suffers from this pain. Do you think that is happening with you? Do you think that we should go on that line and talk about it? At least open the door so that a woman can enter in that door. Not, if not now, later on, and ask about that. It's okay to talk about it. It's okay to resolve. It is totally confidential and there is a support available. And it is seen that if you address that, your pain gets better. Do you want to talk about it? And then explore that what kind of trauma the patient has undergone or person has undergone, and how we can help them to heal that, that trauma. I would like, we need to do that.
Great.
Did I answer?
Yes. Thank you so much. And thank you for the session. It's been wonderful. Thank you.
Thank you. Thank you. Thank you for attending, all of you.
Dr. Vaishali, I have a question as well. You've spoken a lot about management of, pelvic pain, management of endometriosis. Is this a curable condition at all? Is there any chance that a woman can be fully cured of endometriosis?
Yeah. So, no. Okay. So, see, diabetes, is it curable? No. Hypertension, it is curable? No. Yeah. But now I'll go back to what I said. Okay. So the pain, chronic pelvic pain, is addressed when it is affecting your quality of life, right? So our aim is to treat the chronic pelvic pain so that women are assisted to enjoy their life. Okay. So it's a combination of giving them medication and giving them non-medication support so that they can get on with their life and enjoy their life. Okay. So that they don't suffer so much that their physical well-being, psychological, social well-being gets affected. Okay. So first, no, we can't take away endometriosis. Yes, in severe endometriosis, we do drastic surgeries, taking out the uterus, ovaries, but there is no guarantee that we take away the whole endometritic patches, because there can be small endometriosis, like endometriosis in brain. How are we going to take it out?
Yeah.
Okay, sitting on the nose, nasal cavity, we can't take it out. Okay, so the tissues are there. They will stop working once the woman hits the menopause, you know. But unfortunately, after menopause, there can be fibrosis, and that can cause pain. So the pathway is there. What we need to do is that abolish that pathway. You know, there is a way to abolish that pathway. We can do that. Okay, and there is a lot of evidence which is getting gathered that we can do that. So no, we can't take away the endometrial tissue, but yes, you can be pain-free. Yes, definitely you can pain-free. I'm looking into your eyes, Pooja, and telling you, yes, you can be pain-free. We have to work
Thank
together.
You so yeah. Thank you for that, Dr.
Yeah.
Vaishali.
Yeah.
Does anyone else have any questions for Dr. Vaishali? All right. I mean, I think I speak for everyone online today when I say that that was such an informative and eye-opening session, Dr. Vaishali. Thank you so much for sharing all of that valuable information with all of us. Now, like we mentioned at the start of the session, DPV Health have 2 sexual reproductive health hubs located at our medical centers in Broadmeadows and Mill Park. So if anyone here or you know anyone who needs support, please reach out and book an appointment with our specialized nurses team or our GPs. For any further information about our women's health services, please visit the DPV Health website. We have a section dedicated to women's health. To book an appointment, you can call the 1300 number, which is 1300-234-263, and select option 1 for medical services, or you can book an appointment online via the DPV Health website.
Thank you very much, Pooja. Before all of you go away, we got a third webinar coming, and that's going to be equally interested or more interested, because not all people, not all women suffer from chronic pelvic pain, but all of us go through menopause, and we have never talked about or learned how to cope with that. So please come back and we'll talk more about menopausal symptoms. Okay.
Yes, I was going to get to that. That was the last
slide. Sorry, I stepped in.
Thank you so much for doing that. Our last and our final session on the Women's Health Matters webinar series is on perimenopause and menopause, and it's on Thursday, 16th of October. So there's about a month from now. So please, we encourage anyone within your networks, anyone you know that may want further information about menopause, to sign up for that session and attend. And yeah, looking forward to seeing a lot of you back there. Thank you so much to everyone who took the time to join us today, and enjoy the rest of your day.
Thank you all. Bye. Enjoy the rest of the day.